hematological cancers and solid tumors, which now affect any organ of the body. So for the hematological tumors, or what we call blood cancers, we have the leukemia and lymphoma. And in each of those categories, there are different subcategories. Okay? For the solid tumors, as I said, it can affect any organ, so you can have brain tumors, eye tumors, kidney tumors, liver tumors. So basically, it can affect even the muscle tumor like rhabdomyosarcoma, or even the soft tissue. So the cartilage, the fat, the connective tissue. So we call that soft tissue sarcoma. So basically, those are the two components of childhood cancers we have. But under all that, there are some sections of that. Childhood cancers are are different from adult cancers, where you find the adult cancers you can find a cause in terms of lifestyle changes or environmental changes. For childhood cancers, it's different. We have not yet found the main causes of childhood cancer, and that could be explained by the numbers. The numbers are not that many. So you find that even studies that have looked at childhood cancer, looking at the causes, are few, and even the quality of those studies might not be able to like apportion a risk to the cause of the childhood cancers. However, they are like hypotheses. So in the risk factors, you can say there's that intrinsic to the body, and that mostly is a cause genetic mutations. So a gene is, you find genes in the cell. So there are two types of genes, mostly in the body. You have the proto-oncogenes and tumor suppressor genes. So the proto-oncogenes are what give instruction to a cell to grow, to divide, and make more cells. While the tumor suppressor genes are the ones which halt division. So when you have mutations in either of those, so they can lead to uncontrolled cell growth, because maybe the tumor suppressor gene is not working to sort of halt that process, okay? Or even it's used in the repair of the cell. So if it does not repair the mistakes, then you find that the cells are dividing with a mistake going forward, and this can lead to uncontrolled cell growth. So we usually think most of the risk that comes with childhood cancers is mostly genetic. In terms of the environmental risk, and there's a hypothesis that there is exposure to infectious causes such as viruses. We have seen, yes, in some cancers, when you look for certain viruses or certain infectious agents, you find that they are positive. But that doesn't go to say that that is a cause. So we think there is a risk to exposure to infectious agents such as viruses can pose a risk to certain childhood cancers. We cannot really apportion a cause to it. It's also known that some exposure to chemicals, pesticides, or air pollution has been associated with childhood cancer, but we can't really say that is a cause. Um, what we know for sure, and that has studies have actually shown some evidence to cause childhood cancer, is exposure to radiation and also prior chemotherapy. So you might find a child with cancer, and once we treat, then they are at a higher risk of getting another cancer infection just because of the exposure to the prior treatment like chemotherapy or radiotherapy, which is the use of ionizing radiation. For children, we usually do not screen for cancers, partly because what are you going to screen for? So, what has helped us, even as we're passing this message of early diagnosis, is to identify these early warning signs. So when you find a child maybe with fever that is persisting despite use of treatment, antibiotics, and the likes, and they're not improving, you should suspect that this child could actually have cancer. Other signs are weight loss. Children tend to eat and are well nourished and they grow. But then you find a child who's not gaining weight or not thriving, regressed milestones. So they're not achieving their milestones. Then you have to have a high index of suspicion. Other symptoms are anything unusual, like a lump in the neck, or a mass, or the stomach or the abdomen is just growing. So, like a swelling in the stomach, that you can maybe feel it when you touch, and it was not there before. So, those are things that you need to be very suspicious of. Other things are other signs and symptoms. You have night sweats. It's not usual to sweat a lot at night, or poor appetite, refusing to play for children. Children love to play. I mean, if you start finding a child who's isolating themselves, not wanting to play, not wanting to socialize, you might want to go and do some investigations. There's a type of eye cancer called retinoblastoma. So it's so simple. When you take a picture of that child, you just see a white reflex in the pupil. Then you want to further investigate for that. Headaches are also not common in children. So if a child is coming in, day out, I'm having a headache, I'm having a headache, then that's an issue. And so you want to investigate. It could be a brain tumor. And the child just says for months or for days, I'm having a headache. That is it. Feeling tired, okay, can point out to anemia or bleeding, bleeding under the skin, nose bleeding, bleeding in the mouth is not common, and also joint pains. So, or what they say, the bone pain. So we know joint pains and we say, oh, did you have trauma? Did you fall? And there are those certain pains it cannot be explained by even being hit or being falling. Then you want to investigate that. So early detection of a disease is where you are able to pick up a certain symptom or sign and want to explore further to see whether this child has cancer. Because once you detect it early, then you start treating early, and that actually saves lives because you find that their chances of cure is higher when you diagnose early. When you come in late, there you find that first of all the quality of this child has gone down from the time the child is sick. You're using more money to even move from one facility to another, so the financial strain is higher. And lastly, it can cost a life. So you might find the child will die sooner than before even treatment is attained. So early detection is important in order to start treatment early and so as to aim for a chance of cure and improved quality of life. So the treatments are in three categories. So you have the drugs, which we call chemotherapy. So drug treatment for different cancers. So you can have the general like protocol for as a different childhood cancer. So general, like for example, for acute lymphoblastic leukemia, we shall treat with a certain regimen. So that is general chemotherapy. But you have certain characteristics of a disease that you might want to target that particular disease. So that's called targeted therapy. It's still the chemotherapy, but it's targeted to something unique in that particular cancer. So that's the first type of treatment, chemotherapy. The second one is surgery. We usually collaborate with the pediatric surgeons or depending on the site. of the cancer, we collaborate with surgeons so that because that is an important modality in order to achieve local control. And lastly, there is radiotherapy. Radiotherapy is basically the use of ionizing radiation, sort of to control the disease and even to treat some types of cancers. Those are the three that we have in the country currently. There is data. There are studies that have been published, and I see children cancer is quite rare, or rather, we do not have the numbers compared to adult cancers. So you find that even the designs we're using are mostly retrospective. We look back, so we would use hospital records to just see the number of children who have a particular type of cancer. So there was a study that was done in Kenyatta Hospital. They looked at the incidence of childhood cancers while in this Kenyatta National Hospital between the period of 2009 and 2019. So it was a 10-year retrospective study. And from their analysis, they found that acute lymphoblastic leukemia was the commonest cancer in children, and that is actually world over. It's the commonest type of childhood cancer, leukemia. It was followed by retinoblastoma, which is a cancer of the retina. The retina is in the eye. Then followed by lymphoma, another type of hematological malignancy. Another study was done in Western Kenya at Moi Teaching Referral Hospital. It was a 5-year retrospective study. It was done between I think 2006 and 2010. For them, it was a contrast. They found that the lymphomas were higher, so that is the non-Hodgkin's lymphoma, then followed by leukemia, okay, leukemia at 15%. But even if you are to search, those are the studies you're finding out there in the scientific pages. Yeah. So a lot is needed in terms of publishing of this data or even gathering the information in a well thought out manner. So we have hospital-based registries, cancer registries, that information is sent to the regional registries and finally it ends up in the national cancer registries. It needs to be more coordinated and probably even the data coding needs to be done in a more accurate way. So what we have published might not be, it might just be the tip of the iceberg. What we are seeing, there might be more and more cases out there that we not. So we are getting started. A lot, childhood cancer, a lot of information, a lot of sensitization is happening now. I think in the past, it was there was not much information, so people would dispute that there's actually cancer in children, and this is just basically because of we were not sensitizing on the ground the health workers, the parents, on what to do. So a lot needs to be done to capacity building. So we need the specialists to actually care for these children. And when I talk about specialists, I just don't mean the doctors. I mean even nursing care, palliative care, nutrition. So it's basically a multidisciplinary. And I think the country is moving forward by identifying that yes, we need all these people on board. We need to train these healthcare workers so that they can be able to work as a team and be able to care for these children holistically. The data. We need data to inform some of these policies. So you can't say that, oh, we see a lot of children with this particular cancer, and when you're asked, show us the evidence, there is no evidence. So we need to really think through how to collect this data and how to be able to interpret it, so that with that information, then you can make sound and solid strategies, health strategies, in order to be able to reach the care for these children. And there is a national cancer initiative or a committee in the ministry, under the Ministry of Health, and it is bringing in together all the key stakeholders in order to brainstorm and strategize on how to move forward as we treat these children with cancer. So we might not be there yet, but we are making key strides going forward.